subdivided into somatic, natural-based, and psychological. This is based on Cartesian dualism, which somatic, res extensa, that is corporeal substance, and psychological, res cogitans, thinking substance. Actually, attributing this strict division to Descartes is a bit unfair on Descartes, because he was well aware of the unity and interdependence of corporeal substance and thinking substance. In his sixth meditation, he said, certain confused modes of thinking arising from union and apparent fusion of mind and body, and my mind and body compass a certain unity. Functional somatic syndrome is defined as disorders of any system based on clinical symptoms in which symptoms cannot be explained by the presence of structural or tissue abnormality. It is important for the surgeon. Is it important for the surgeon? I would say yes, because he needs to make a positive diagnosis, avoiding unnecessary investigations, avoiding unnecessary surgery, unnecessary referrals, discussing treatment options with the patient, and educating the patient about his disease. And the incidence is quite common. It's involved in 20% of cases in primary care and 25 to 35% of patients in the outpatient population, so it has to be considered. An embryologic basis for this interdependence has been proposed, but the brain is actually ectodermal origin and the GIT endodermal and mesodermal origin, and in my opinion we have to look elsewhere for explanations. The etiology is actually an imbalance in serotonin function involving interactions. And we have early life influences such as genetics, environment, abuse, and life stresses such as psychiatric illness, social effects, and coping, having a physiological effect both on sensation and motility of the GIT. And this causes symptomatology. The symptomatology itself may constitute another life stress. Biochemical aspects have been proposed, especially regarding CNS influences on pain and sensory processing, and there are facilitatory substances, such as the ones in the left column, and inhibitory substances in the right column. There is also functional MRI evidence in chronic pain conditions, objective evidence of augmented pain processing in a broad range of pain states. Depression and pain are overlapping neurobiological processes, and how individuals think about their pain can affect both sensory and affective processing of the pain. Functional somatic syndromes can affect any system in the body, but we're here at a surgical gastroenterology session, so these are the symptoms that are most of interest to us today. Vomiting, abdominal pain, difficulty in swallowing, nausea, bloating, diarrhea. They all can be red flag symptoms of organic disease, so one has to be very careful. So how does one go about diagnosing this? It's best to have a positive diagnosis, not just by exclusion. There may be multiple symptoms, often occurring in different organ systems, including fatigue, memory difficulties, and sleep disturbances. Symptoms do not fit into any clear-cut physiological or pathological mechanism. Symptoms are vague or exceed objective findings. It usually runs a chronic course. There may be presence, as often is a presence of a psychiatric disorder. History of diagnostic testing is extremely common and is evidenced by voluminous notes. There is often rejection of previous physicians. There may be indicative observations from other members of the medical team. And however, always remember that the red flag symptoms of organic disease and be ready to come back from your preconceived ideas. There are other features which are a bit less important. It is more common in females by 1.5 to 2 times. There are strong familial and genetic underpinnings, so taking a family history of pain and other symptoms is important. It's triggered or exacerbated by stressors, and normally there is generally there's a normal physical examination, except perhaps diffuse tenderness everywhere and non-specific neurological signs, abdominal bloating, and so on. Symptom complexes of functional somatic syndromes affect the GIT, like in functional dysphagia. Following what has been said a while ago, it may be independent or even following Nissen fundoplication. So it's not said that all dysphagia following Nissen fundoplication is caused by functional somatic syndromes. Certainly one cannot say that, but it can follow that. And there is experimental evidence to show this. Erophagy, non-ulcer dyspepsia, irritable bowel syndrome, chronic idiopathic constipation. It may also affect other systems such as tension headache, fibromyalgia, chronic fatigue, non-cardiac chest pain, functional chronic back pain, persistent yawning. Note that these patients tend to flit from one complex to the other, and you may have them at one time presenting with one set of symptoms and then another, and that's one of the things that points them out. Of special interest are erophagy and irritable bowel syndrome. There are 2 types of erophagy, which you can actually detect clinically. And the first, swallow there does not pass through the cardia, and there is rapid and repeated burping, perhaps with attempts at controlling this because the patient is embarrassed during the clinical encounter. You can notice this. It's often interspersed with swallowing, repeated swallowing of saliva. Then there is a second type where the swallow there distends the stomach and variably the intestines, with epigastric and abdominal discomfort, temporarily relieved by burping, passing flatus, or else bloating. Irritable bowel syndrome is, similarly has 2 types, the diarrhea predominant, which is associated with anxiety more often than not, and constipation predominant associated with both depression and anxiety. There is some evidence that in IBS, the brain itself amplifies the pain signals, whereas in chronic pain syndromes, there is an increased afferent pain impulses. And as we said, both IBS types are frequently associated with psychiatric conditions, personality disorders, and environmental stresses. Let me remind you of the Rome 2 criteria for the diagnosis of IBS. Recurrent abdominal pain and discomfort for at least 3 days a month for the previous 3 months. Onset of symptoms of more than 6 months, associated with 2 more of improvement of pain with defecation, change in frequency of stools, and change in the appearance of stools. So how does one manage these cases? A thorough and clinical history and physical examination is not only of diagnostic importance, it has also therapeutic implications. Goal-seeking investigations must be used because over-investigation may be harmful, very harmful in these patients. Psychological evaluation, empowering careful explanations, help the patient to cope with symptoms through advice, drug therapy, biofeedback, psychotherapy. Exercise, which is a break from oppressive situations and improve self-esteem. Pleasurable pastimes. reducing sources of stress, avoiding unrealistic goals, and communicate and eventually refer to a primary health team. Note that I said primary health team. These patients, if referred to a psychiatric team, often, very often, do very badly. Dangers of failure in diagnosis: unnecessary surgery. I've seen a few of these. Untreated anxiety and depression will inhibit response to conventional symptomatic relief. Untreated, these patients become chronic clinic attenders. Over-investigation may aggravate symptoms. Complications may arise from invasive testing. Drug dependence to pain therapy. Poor doctor-patient relationship and multiple referrals worsen the condition. And complications from the underlying psychiatric disease or personality disorder. This can be so severe, like suicide and so on. The importance of context has been known for a long time. Hippocrates said the patient may recover his health simply through his contentment with the goodness of his physician. And there are several factors which are involved in this context effects, how context affects on outcome. There are treatment characteristics such as color, shape, and size of the medication, patient characteristics, illness, beliefs, anxiety, patient-doctor relationship involving suggestion, reassurance, explanation, the healthcare setting, whether it's at home or in hospital, and doctor's characteristics like status, seniority, gender, etc. So we conclude that the surgeon cannot afford to ignore psycho, neuro, biochemical, immunological interactions which affect his patient's body. Ignoring this would relegate the surgeon to the role of a technician, which we really do not want.
Thank you very much for finishing in time. Do we have any questions from the floor?
Thanks very much indeed. That was very interesting. We get the general sense that we're seeing more and more functional disorders rather than less and less. Why do you think that is? Is it a society response looking for a diagnosis? Or why is it? Or is there an actual increase in these?
I think more of these are coming to the surgeon, because unfortunately, even at primary level, they are not trained for it, not taught about it. It's not spoken about very much. And people have become so technologically minded that they think they can solve everything with technological diagnostics and so on. And really, this makes things worse, and therefore, we get more of it. It filters to the surgeon. That's why the surgeon has to be really quite clued up with this, and it's not something extraneous or ridiculous to talk about.
Could I ask a follow-up? I'm seeing more and more patients who have acalculous biliary pain, and we're doing a lot more HIDA scans, particularly in the last few years. There's been my radiation, my nuclear medicine radiologist is delighted with me because I'm giving him lots of business. What do you think of operating on gallbladders which have borderline or low ejection fractions in the absence of stones?
Well, this is one of the dangers involved, because I have a suspicion that many of these don't really need treatment and really don't need so much investigation. Many of them can be diagnosed clinically. I was mentioning the patients who come and sort of burp-like or try to control a burp repeatedly during the clinical examination. This is immediately noticeable if you are aware of it. If you're not aware of it and the patient then complains of epigastric and the right hypochondrial pain, you might be tempted to continue investigating. This will make the patient worse. I'm sure that modern day life stresses and so on are greater then we set about in the sun. But I don't think that even Stone Age men set about in the sun. They had things to do. So life stresses do affect these things. But what we must guard against is missing them or making the patient worse by over-investigating, or worse still, operating. I've seen people with erophagy having a laparotomy. Sometimes erophagy occurs even after blunt trauma. So one has to be well aware of the conditions.
Thank you very much. By this, we'd like to ask Professor Terzi to come up to the floor. And he's a professor of